My name is Professor Jean Bourhis. I'm Chief of Radiation Oncology Department at the Center Hospital Université Vaudois in Lausanne, Switzerland. I specialize in radiation oncology and specifically in the treatment of head and neck cancers. Today, on behalf of my co-authors, I would like to discuss our article titled Extended Follow-up of a Phase 2 Trial of Xevinapant plus Chemoradiotherapy in high-risk locally advanced squamous cell carcinoma of the head and neck, a randomized clinical trial. This article was published online in the European Journal of Cancer in January 2023. It reports long-term follow-up analysis from the phase 2 trial. The primary data were published earlier in 2020. Head and neck cancer is one of the most common diagnosed cancer types globally. In 2020, head and neck cancer accounted for over 850,000 new cases and 400,000 deaths worldwide. Over 90% of head and neck cancers are classified as squamous cell carcinoma of the head and neck, and around 60% of patients are initially diagnosed with locally advanced disease. Squamous cell carcinoma of the head and neck includes cancers of the lip, of the mouth, the tongue, of the throat, and the larynx. Approximately 50% of patients with locally advanced squamous cell carcinoma of the head and neck are unresected. That is, they do not undergo surgery. And the current standard of care for these unresected patients is cisplatin-based chemoradiotherapy. Despite curative intent treatment, half of the patients will have local relapse or develop distant metastasis, generally within 2 years of completing the chemotherapy. And median overall survival for these patients with disease recurrence is approximately 12 months. Standard of care for unresected locally advanced squamous cell carcinoma of the head and neck has remained relatively unchanged for more than 2 decades, and novel treatment options are urgently needed to improve the outcome of these patients. Xevinapant is a first-in-class, potent, oral, small molecule inhibitor of apoptosis protein, so-called YAP inhibitor. Currently, it is under investigation for the treatment of locally advanced squamous cell carcinoma of the head and neck that is sought to restore cancer cell sensitivity to apoptosis and thereby enhance the efficacy of chemotherapy and radiotherapy. Tumor cells can avoid cell death by suppressing apoptotic signaling, for example by overexpressing YAPs, which regulate apoptosis via the inhibition of caspase activity. Overexpression of YAPs is associated with a poor prognosis in locally advanced squamous cell carcinoma of the head and neck, and in preclinical models, it has been shown to diminish the effect of both chemo and radiotherapy. Xevinapant inhibits X-linked YAP, XYAP, and cellular YAP 1 and 2, so-called CYAP 1 and 2, releasing the blockade on downstream caspase activity, which is crucial for apoptosis and anti-cancer activity of both chemotherapy and radiotherapy. Inhibition of CYAP 1 and 2 may also facilitate the immune cell activation by activating the non-canonical NF-kappa B signaling, which induce the production of inflammatory cytokine in response to tumor necrosis factor receptor signaling. A two-part phase 1/2 clinical trial evaluating the safety and efficacy of Xevinapant in combination with chemotherapy was performed. The trial began with an initial phase 1 period of dose escalation, which identified 200 mg per day as the recommended dose for the phase 2. Subsequently, in the double-blind, multicenter randomized phase 2 portion of the study, 96 patients with previously untreated, unresected, locally advanced squamous cell carcinoma of the head and neck were randomized to receive either Xevinapant plus chemo-RT or placebo plus chemo-RT. Most patients had stage 4 disease. All patients were heavy smokers with a median smoking history of 40 pack years. Only a small number of patients were HPV positive, with 3 patients in the Xevinapant arm versus 5 in the placebo arm. In the double-blind randomized phase 2 portion of the study, Xevinapant plus chemo-RT was compared with placebo plus chemo-RT in these patients with unresected locally advanced squamous cell carcinoma of the head and neck. The primary results of this study were published by Sun in Lancet Oncology 2020 and reported significant improvement in the rate of local regional control at 18 months, which was the primary endpoint. Here, I will discuss the extended follow-up results from this study. We are reporting extended follow-up data for progression-free survival, PFS, local regional control, duration of response, overall survival, and long-term safety. Efficacy results for PFS, local regional control, and duration of response were analyzed with 3 years of follow-up after the last patient was randomized, along with safety results. Overall survival was evaluated with 5 years of follow-up after the last patient randomized. Long-term safety was analyzed in terms of late onset toxicity, which were defined as adverse events that started or worsened 30 days or more after the end of the treatment. Xevinapant plus chemo-RT improved progression-free survival versus placebo plus chemo-RT, with a 67% reduction in the relative risk of disease progression or death, and the probability of being alive and free of disease progression after 3 years was 72% with Xevinapant versus 36% with placebo. The relative risk of death was reduced by 53%, and the probability of survival after 5 years was 53% in the Xevinapant arm versus 28% in the placebo arm, which is nearly a doubling of overall survival rate at 5 years. The overall survival was also assessed in patient subgroups. The overall survival benefit of Xevinapant was generally maintained across subgroups, which included HPV status, smoking status, cancer localization, which is tumor sites, nodal involvement, TNM stage, and also alcohol consumption status. Now, the relative risk of local regional failure over the study period was reduced by 54% in the Xevinapant plus chemo-RT arm versus the placebo plus chemo-RT arm. And the probability of being in local regional control 3 years after randomization was 78% in the Xevinapant arm versus 56% in the placebo arm. And over the study period, there was a 79% reduction in relative risk of death or disease progression after initial response for patients who received the Xevinapant. The probability of maintaining a response 3 years after initial response was 79% in Xevinapant arm versus 36% in the placebo arm. Now, if we look at subsequent anti-cancer therapy for progressive disease of the primary cancer, it was 33% of the patient in the Xevinapant arm versus 40% of the patient in the placebo arm. And the most common subsequent therapies were chemotherapy, cetuximab, and immune checkpoint inhibitor, which are consistent with the current standard of care. Now, regarding late onset of toxicities of any grade, it was reported to be 81% of patients in the Xevinapant arm versus 70% of patients in the placebo arm. And if we're focusing on grade 3 or higher late onset toxicities, it was reported to be 27.1% in the Xevinapant arm versus 25.5% in the placebo arm. The most common late onset toxicity were dry mouth, with 35 versus 25% in Xevinapant versus placebo, respectively. And we can emphasize that the majority of the late onset toxicity was grade 1 and 2 or 2 toxicity. By the end of the study, 21 of the 48 patients died versus 29 of the 48 patients died. But none of these deaths were attributed to study treatment and especially to late toxicity. So what did we learn from this study? The long-term analysis from this study show the continued efficacy benefits with Xevinapant plus chemoradiotherapy versus placebo plus chemoradiotherapy in patients with unresected locally advanced squamous cell carcinoma of the head and neck. This is the first study in decades to demonstrate superior efficacy benefits versus standard of care chemoradiotherapy in patients with unresected locally advanced squamous cell carcinoma of the head and neck treated with curative intent. It is also the first study to demonstrate proof of concept for the clinical effectiveness of targeting YAPs in a randomized placebo-controlled phase 2 study. Overall benefits, survival benefits were maintained across all the subgroups, as we saw. PFS and duration of response were markedly improved with Xevinapant, and over a period of at least 5 years, the risk of death was more than halved for patients in the Xevinapant arm compared to those with the placebo arm. Now, regarding the safety profile of Xevinapant, it remained manageable, and with extended follow-up, there was a similar proportion of late onset toxicities of grade 3 and more, which occurred in each arm. These results are encouraging. These are encouraging data which suggest that Xevinapant may be able to improve cure rates in patients with unresected locally advanced squamous cell carcinoma of the head and neck when added to standard of care chemoradiotherapy. Now we have the randomized phase 3 tree-length study, which is being conducted in the same patient demographic to confirm the efficacy of Xevinapant plus chemo-RT versus placebo plus chemo-RT. Thank you.